about the surgical management of hepatic metastases, resections, radiofrequency ablation, and transplantation. And he is Professor of Surgery at the Department of Surgery and London Health Sciences Centre in London, Ontario. Dr. Quan.
Thank you, Sharif, and thank you to Robin and Maureen for inviting me to speak today. And thank you for all that have attended, including a number of familiar faces, some of you whom I've had my hands in your belly, and others that I think may meet that fate as well. Before I get started, I think from a medical point of view, the carcinoid and neuroendocrine tumors are quite an interesting group of tumors for us to treat. And in fact, because of the chronic and indolent course of the tumor, it may actually pave the way and form a prototype in terms of chronic cancer treatment, especially now that we're developing better and more effective chemotherapeutic agents for other types of malignancies. So there is a lot to be learned, and for you patients, we're learning from you and with you. So the topic of metastatic neuroendocrine tumors, and specifically here we're talking about liver metastases, it's quite a common and frequent event when it comes to patients who have carcinoid tumors. And I'll use carcinoid and neuroendocrine tumors interchangeably here. I apologize ahead of time. But up to 50% of people who present at the time of their primary presentation will present with synchronous metastases to the liver, that is, metastases that occur or are discovered at the same time as the primary. In those patients that have primary tumors that are greater than 2 centimeters, the chances of developing either a recurrence or a metastasis is up to 80%. By far the most common site of metastasis is the liver, although we do see other organs involved. But primarily the liver is where the most common site of metastasis is. And as Dr. Boudreau alluded to earlier, the prognosis certainly worsens once metastases are found. Now, unfortunately, the majority of patients who develop metastases will have diffuse disease. And by diffuse, I mean multiple tumors within the liver that are not necessarily confined to one area, which then makes it difficult for us to approach from a surgical point of view. The, I guess, strange thing, and we've heard over and over again, and I think all of you know that these tumors are slow growing. And one of the strange things that we do see on occasion is that some patients will have their primary treated, and many, many years later is when they actually present with their metastases. Fortunately for that smaller group of people, they're probably in a better prognosis category. And again, as we've heard, functional tumors can present with quite dramatic and occasionally life-threatening syndromes. So in the treatment of metastatic neuroendocrine tumor to the liver, there are many different options in terms of treatment. But it's partly because of this variety of treatment options that the management is both controversial and complicated. Controversial in that because of the different modalities that are available to us, the many different centers that are treating larger numbers of patients with neuroendocrine tumors are using different combinations of these therapies, and it makes it very difficult for us when we are trying to interpret the literature in terms of what is in fact the most effective therapy. And the problem here is that there are a number of centers around the world who see I guess, a concentrated group of patients such as yourself. The problem there is that there are relatively no prospective studies, and certainly very few when it comes to the surgical side of treatment. And as a result, there are really no universally accepted treatment algorithms. Now, in terms of the surgical literature, one of the inherent problems with any part of the surgical literature, I guess, is that there is quite a significant amount of selection bias, and that is the patients that we choose for surgery are usually going to be in a better category of patient patient in terms of your performance status, comorbidities, and as a result, I think it's not surprising that we see reasonable results from the surgery side of things. But to compare surgery with non-surgical treatment in liver metastases of neuroendocrine tumors at this point in time is fraught with many pitfalls, and as a result also contributes to some of the confusion that we have when trying to interpret the literature. Bottom line is that multidisciplinary and multimodality treatments is what is necessary. Now, this is one of the problems that I guess illustrates part of what I was just saying with the last slide, and that is there isn't a well-accepted classification system of neuroendocrine tumors. The most commonly used one is that of the WHO classification, which has been mentioned several times already today. But these are quite broad categories, as you can see, and although it may help to classify individuals with these various disease processes into these three categories. And it's useful because as a group, these tumors are quite heterogeneous. But when it comes time to actual clinical decision making, this broad classification doesn't necessarily help us very much. The diagnosis of metastatic neuroendocrine tumors is also complicated in that we can approach this from many ways. And in fact, what we've discovered with more and more experience is that we basically use every method that we have available to us. So the most common biochemical markers that we use would be the urinary 5-HIAA and the serum chromogranin A to try to detect the presence of active disease. Other biochemical markers are, I would say, probably more center-specific in terms of certain centers having a greater interest in some of these, or those that are used in the context of research projects. So the mainstay of diagnosis of metastases then remains imaging. And for you patients, I think you know all about this, spending countless hours either waiting or actually having the procedures done. And again, in general, we do rely on virtually every method that I've listed here to try to give us an anatomic handle as to where these tumors are and which tumors need to be treated. Similarly, the treatment of metastatic tumors has a long list here as well. I won't get into too much of the top few categories here. Concentrating primarily on surgery, and again, we've already heard that surgery gives us really the best chance for a possible cure. With regard to the different types of surgical procedures that we can do, the main ones that we mainly focus on are that of resection and radiofrequency ablation, or a combination of the two. Now, with resection, the two main goals that we have there are either complete excision, which is probably in a smaller proportion of patients, or that of debulking, which I'll get into. Lastly, I'll talk briefly about transplantation, which is the most controversial of the surgical treatments. Before we start with that, though, I'll just give a brief blurb about carcinoid crisis, which has been, again, alluded to earlier. Carcinoid crisis can occur in any patient who's undergoing treatment of their carcinoid tumor, whether it's through an ablative approach or through an actual surgical approach where we're manipulating the tumor and possibly pushing some of that hormone directly into the vascular system. It's thought that up to 10 to 15% of patients who are not pre-medicated prior to their treatment can develop this, and it manifests as very severe flushing, hypotension, bronchospasm, and in some cases, shock. Now, in our surgical series, we've actually adopted the first route of prophylaxis against carcinoid crisis, and that is a subcutaneous injection of octreotide, usually at a dosage of 500 micrograms that we give 2 hours before surgery. Others have advocated these other protocols as well, and in reality, it's probably, again, a combination of the preoperative prophylactic dose that's given, as well as intraoperative doses that may be necessary as the procedure goes along. So the overall, and the good news is that the overall survival of patients with metastatic carcinoid tumor appears to be improving. The median survival appears to have improved over the last decade and may reflect some of the changes in terms of our approach to treatment of the metastatic tumors. It's widely accepted now that aggressive surgery is the way to go whenever it's possible, and I think that probably most of the physicians here from centers who do a large number of these types of operations, that we are all trying to adopt a more aggressive approach, and I think there's just a slight variation in terms of the degree of aggressiveness. So one of the things that we have to be quite clear of right at the beginning is that we have to have quite well-defined goals if we're contemplating doing these aggressive procedures, or by aggressive I mean larger resections. The goals of surgery, well, for any cancer surgery, always the goal, whenever possible, is that of cure. But as I said, in reality, those patients that already have metastases, even those that where we're able to completely excise what we think is all of the tumor that's present within the liver, the reality is that really the cure rate is still going to be quite low, and probably somewhere in the order of 10 to 15%. So the main goal, I would say these days, apart from patients who have functional tumors that are causing symptoms, and especially those that are refractory to medical therapy, that's another clear group of patients who should be operated on when possible. The goal otherwise, I would say these days, is improved overall survival and improved disease-free survival, which we appear to be achieving with the more radical surgical procedures. Dr. Diaz mentioned earlier this morning that there may be a role also for radical surgery in the prevention, or in the, prevention of progression of carcinoid heart disease. One thing to be clear on, though, is that recurrence after surgery is still very common, although anecdotally it appears that those recurrences appear to be somewhat more slowly progressive. Now, I guess the main reason that we've adopted this more aggressive approach is that the morbidity and mortality rates associated with liver resection have dropped quite dramatically, I would say, in the last 10 or 15 years in large reported series for various indications, not necessarily just for neuroendocrine tumors. And as a result, this mortality rate, which at many centers now are reported to be 1 or 2% or less, have allowed us to expand our indications for liver transplant, or for liver resection. In terms of debulking, I think the most accepted number that most surgeons will agree to operating on people is when we are able to achieve a 90% tumor volume debulking. Now, one of the questions from the audience earlier was how do you determine tumor volume, and that's one of the difficulties that we have with this as well. And I would say for us, and probably most other centers, is more of an estimation rather than an accurate calculation, although there are some centers that are trying to do more precise volumetric studies of the tumor relative to the normal liver tissue. But we certainly adhere to the recommendation of 90%, which was popularized by a study that was put out through the Mayo Clinic. But this number may, in fact, change. And I'm not sure if Janice is going to talk to us a little bit later after this talk about where they're approaching this at the University of Calgary. One of the other important differences in terms of doing liver resections for carcinoid tumor as opposed to other types of malignancy is the margin status. And certainly in the other malignancies, if we're not able to confidently obtain a clear margin, we usually will not proceed with resection. But this is quite different in the carcinoid group in that even with debulking of 90% or more, there does appear to be an improved survival rate overall. Some of the other things that we're doing that are improving our rate of resectability for patients who need a liver resection are some of these that I've listed here. This is just a short but not exhaustive list. As I mentioned earlier, the combination of resection and radiofrequency ablation, we're doing that more and more now with various tumors, and I would say arguably that probably the carcinoid and neuroendocrine tumor group are best suited for the combination approach, despite the relative lack of data. Portal vein embolization is a technique that we use to, before we do any surgery, and this is done by the radiologist, to block off one side of the portal vein, either the left side or the right side, which then induces hypertrophy on the other side. That is, the other side gets bigger. And the reason for doing this is that if we're concerned that the piece of liver that we leave behind after we've resected the tumor along with the liver, normal liver with it, if we're concerned that that's too small, this then gives us one avenue to try to improve the volume of liver that's going to be left behind. And this has been done in many, many centers now and has quite a high degree of safety. Staged resection is something that's just more, I would say, recently been advocated with regard to liver surgery. What we do here is that we take out a piece of the liver in one setting, then close the patient back up and allow regeneration, which takes place usually within 4 to 8 weeks, to occur in the piece that stays behind. Once that regeneration has occurred, and to our satisfaction, then we take the patient back to the operating room a second time and then remove the remainder of the tumor load, depending on where it is in the liver. And as Dr. Boudreau said, location is of utmost importance in terms of how we approach this. Finally, Dr. Roshinsky gave you the results of some of our local experience with I-131 Lapiodol, and certainly it does seem to, well, not necessarily downstage, but downsize a large number of tumors, and it's our hope that in the future we'll be able to downsize some of those that are deemed unresectable and into a resectable stage. So, as I said, the results of surgery for liver metastases, the results are very encouraging, I would say. In greater than 80% of patients who are symptomatic from a functional tumor, they will see improvement, if not complete disappearance of their symptoms. Oftentimes, this is definitely evident shortly after surgery, although a good number of patients, either through recurrences or new tumors, may develop a recurrence of their symptoms. Now, prolonged survival at 5 years, which is an arbitrary number that we use for other malignancies and not necessarily applicable to carcinoid tumor patients, but nonetheless is the standard that we use in other malignancies. 5-year survival in patients who undergo resection appear in general to be improved from about 30 to 40% without resection to approximately 50 to 80% with resection. In general, I would say most of the literature are reporting increased median survivals, and those can be somewhere around the 6 to 8 year mark. What's unknown, I guess, right now still is the efficacy of combination therapies. And I think the reality is that most of our patients are being treated with combination therapies these days. It's rare that anyone gets surgery treatment in isolation. Surgery can be combined with either embolization procedures or radiofrequency ablation. We still don't know for sure what the proper combination is. So this is a table that I lifted from a review article from, I think it was from 2006. The take-home message here is, well, first of all, as you see, the operative mortality is quite low, and in most contemporary series, I would say it would be even lower than those bottom numbers. But on the far right-hand column is the overall survival of these patients. And there you see the figures that range largely from about 60 to 80% 5-year survival. Now, having said that, there are many, many unresolved issues when it comes to surgery for metastatic neuroendocrine tumors. This is just a few of them that I've listed here. I think timing of surgery, that's still an unresolved issue, whether it should be simultaneous or staged, that is with the primary tumor. We are doing some patients very selected, where we do them simultaneously, that is combine a large liver operation with usually a bowel resection. But the nature of our referrals, I think, is that most of our procedures are actually staged. Most patients come with the primary tumor already dealt with, and then present usually to me with the metastases. And then there's also the timing of surgery when it comes to determining how to treat liver metastases versus metastases that are found elsewhere. And in this group of tumors, as well as I think in other malignancies, again, the most common one there being colon cancer, the timing of metastasectomy, I think, is or has recently been put into question, and it may be that going after the metastatic lesions is more appropriate first rather than going after the primary, but I don't think we really know the answer on that. And then I've already talked about the extent of surgery and the amount of debulking that we can do and what's actually acceptable, and I would say that because we're getting such good results with 90% debulking, that maybe we should consider going a bit lower. Whether or not there's any role for adjuvant therapies. We have in a few patients used the I-131 lipoidal chemoembolization as adjuvant therapy. But we, again, are using this in an uncontrolled fashion. And finally, the role of postoperative octreotide and its biological effects on the tumor. This is a constant tug of war that I have with Dr. Kocha. Everyone who has had their surgery, I take them off the octreotide. Only about maybe 3 to 6 months later, they come back on octreotide that Dr. Koch has put them back on, even if they have no symptoms. But there is some soft data that would suggest that survival, once again, in an adjuvant setting may be improved if you give octreotide postoperatively. Radiofrequency ablation. Radiofrequency ablation is a technique basically of burning the tumor or treating the tumor by heat denaturation. It's done, the reason that it's called radiofrequency ablation is that we use radiofrequency, which is basically a high oscillating alternating current, and with that alternating current, heat is generated in between the needle tips of the probes that we use. It's a very safe technique, complication rate in general being less than 10%, and most series, I would say now, reporting less than 5% complication rate. It can be approached through a number of different avenues, either percutaneously, that is done by the radiologist under local anesthetic and sedation, I guess, or laparoscopic approaches, or through open surgery. The advantage of RFA is that you can treat the same tumor or the same liver multiple times. It's been met with very good short-term results in those that have functioning tumors with very good rates of symptom relief. The median survival in the most recent large series from Sipperstein at Cleveland Clinic shows a 3-year or almost 4-year median survival after treatment. It's felt that in general that treatment through radiofrequency ablation may result in a higher recurrence rate than surgical excision. And we're still trying to feel our way with regard to the use of radiofrequency ablation in those that otherwise have unresectable extrahepatic disease as well, and whether or not it is of any benefit to treat these, despite the fact that they have a low complication rate. And like much of the literature in neuroendocrine tumors, there's really no good prospective controlled studies. There's no head-to-head comparison, for example, of resection versus RFA, and it may turn out that maybe RFA is at least equal to that of resection, which may mean that we're resecting too many patients right now. But again, those are unanswered questions. I'll conclude with liver transplantation. Now, liver transplantation for metastatic neuroendocrine tumor has been performed in many, many centers around the world over a long period of time. But at each of these centers, there are very few numbers that have been reported. Recurrence after transplantation is still common, and I would say most reports record at least a 50% chance of recurrence when followed out. It appears that non-carcinoid tumors do worse when they're transplanted. Patient selection is critical, and the reason that it's critical is that we want to bring up the survival rate, the 5-year survival rate of those that are transplanted for this to roughly what we would expect for transplantation of other malignancies, and that is primarily hepatocellular carcinoma. The reason for this is that cadaveric donor organs, cadaveric livers, are indeed a scarce resource. And so it's very difficult sometimes for us to determine what is the proper allocation of these organs. And I think that if we continue to report 50% 5-year survival for carcinoid tumors who are transplanted, that's probably going to fall below the mark of that for hepatocellular carcinoma, for which we're reaching close to 75% 5-year survival. So judicial use of these organs is obviously imperative, and I think that we probably will be able to reach consistently that 75% mark if we are very careful in terms of patient selection. So of the reported series, what's advocated currently is that age less than 50. Certainly absence of extrahepatic disease is very important. Less than 50% of the liver being replaced with tumor. And then finally, a favorable histology, and one of the parameters that we go on is that of the Ki-67 index. So this is a recent report from the French group, which have accumulated a total of 85 patients who've been transplanted. But if you will see from this table, and this illustrates, I think, very well not only patients that are transplanted, but all series of surgically treated carcinoid tumors in general, that there are many centers involved to produce a reasonable final number in terms of number of patients treated. But if you look at each center, on the far right column, there aren't that many places that have a great experience when it comes to treating these patients by transplantation. This is from the same paper, which illustrates the difference in terms of digestive tract-associated neuroendocrine tumors, which are largely carcinoids, versus those arising from the pancreas. And certainly those that are transplanted for carcinoid tumor appear to fare better. And the main column to pay attention to here would be here at the 5-year survival mark of various reports of liver transplantation for metastatic carcinoid tumor. You can see that the numbers are pretty much all over the map, ranging anywhere from 30 to 80%. So I think we need to get a better handle on this, and probably selection criteria is where the first step is going to be. So at the London Health Sciences Centre, we've more recently developed a multidisciplinary team that's been going for a little over 4 years now, I think. And in this 4-year period, we've taken 27 patients to the operating room for attempted surgical therapy of the metastases, and have been able to perform procedures in 23 of these. Most of these will be resection alone, although there are a number where we've combined it with radiofrequency ablation. So far, no perioperative mortality. As I said, we pre-medicate every patient, whether or not they have a functional or a non-functional tumor. We've had 3 patients who have actually had intraoperative hypotension, which we thought may be related to hormone secretion. 2 of these were quite transient and responded quite quickly to a single bolus of octreotide intraoperatively. One outlier was a patient who had already developed carcinoid heart disease to the point where she needed both tricuspid and pulmonic valves replaced. And in fact, the carcinoid tumor was now starting to destroy those valves. And that patient actually required very large doses of intraoperative octreotide. To date, we've actually treated 2 people with liver transplantation. These have occurred within the last year and a half, and both of these patients have done quite well post-operatively. So my final take-home message, I think, is that we need to approach metastatic neuroendocrine diseases using the 3 M's, and that is multidisciplinary, multimodality, and hopefully multicentric trials and collaborative research projects. Thank you again.